That look right to you?
That's what Dan sent me.
So quiet.
Wow, the room is quiet.
A bunch of other bills that we had.
I'm going to start out with a request for everyone. If you have had a family member or close friend, mental illness, or substance abuse disorder, please stand up. Wow. Okay. Okay. It's amazing. It's amazing the number of people in our society today that are impacted by mental illness and substance abuse. And think about what it would look like if we counted not only the people you know, but the relatives and friends that you aren't even aware of have it as well. You may sit down. Oh.
They already have.
Okay, on behalf of the Forum Committee, it's our pleasure to welcome everyone to the 4th Annual Legislative Forum on Mental Illness and Substance Abuse. Of course, this is always a special time of the year, which makes it a tough time of the year to fit things like this in. But nonetheless, we're genuinely appreciative that you are here. And special thanks to our legislators for attending as well. I'll be asking our legislators to introduce themselves in just a couple of minutes. But first, a word from our sponsor. This forum is brought to you by a committee made up of folks from various mental health. By the way, can you hear me?
Now
Now you can. Okay, that's great. Okay, anytime I don't get this close enough, just raise your hand or something. I'll get the point. Okay, made up from various mental health and addictions organizations in our community. They include Mental Health America, Wabash Valley Region, NAMI, West Central Indiana, Valley Oaks Health, Sycamore Springs, Willowstone Family Services, Meridian Health, and the Drug Coalition. Also, our fun little group includes Michael Blood of United Way and also Chris Campbell, one of our representatives. I would like to ask all those who serve on our committee to stand up to be recognized. Okay. Thank you. Okay, thank you. By the way, if any of you out there would like to join our fun little group, you certainly are we'd be pleased to have you. You can just let me know, and we'll make sure you get advised of when our meetings are. We meet generally the first Monday of every month at about 10 o'clock. Okay, by the way, my name is Ken Ritchie, just in case. I'm a volunteer with NAMI. Okay, a special shout out to Tippecanoe County. Due to their generosity, this forum is being live streamed for the benefit of those who are unable to attend. Also, I'd like to thank Chris from the media for being here, and special thanks to them as well. Now, to make our forum a bit more smooth, for those of you in the audience, if during the presentations or during the back and forth of discussion you have a question you would like our distinguished legislators to address, we have a form for you to fill out. You can write down your questions. There'll be people to pick up those questions during the presentations. And after the presentations and the initial responses by the legislators, we will answer, or we will ask as many of those questions as we have time to do it. On the other hand, if you have and this has happened in the past, if you have a personal issue, a question about a specific need for mental health or addiction services for yourself or your family or a close friend, after the forum is over, we would encourage you to either see myself or one of those people who are just standing, and we'll make sure that we find the right person for you. We recognize these issues are difficult and inappropriate in a public setting, but we do want to make sure that your concerns get the proper attention they deserve. And there I go again. Okay, thank you. Okay, now we would like to have the legislators introduce themselves. And I'd like to know if you could, mention the area you represent, perhaps any committees you serve on, and anything else you would like to talk about. We'll start with Sheila and work our way down.
Are these microphones?
Yeah.
Yes, they are.
Okay, thank you. Okay, I'd like to stand so I can see all of you and you can see me, sure as I am. I'm delighted to be here tonight. I serve on 3 committees that I really enjoy, and that's the Ways and Means Budget Committee, of which Dr. Brown is chairman, that's here this evening with us. And I also serve on Veterans Affairs and Public Safety, which includes all of our veterans, PTSD, and some of the problems they're coming home with, along with public safety, our police officers and firefighters throughout the state. In that committee, and it's a very busy committee. And then I also serve on the Education Committee, which had a summer interim study committee that not only talked about teacher pay raises, but also about mandates that the state has had on teachers locally and what they're having to do, 15 hours of going out and career coaching and some other mandates that have been very, very difficult for teachers, and they're not paid for that. When I was teaching and I had Dan Moore in 8th grade, and I also had Mrs. Mavitt's beautiful children that works at NAMI. So I'm very fortunate in that in teaching, I was able to see some of the problems that our children have and know that it's a very important committee to serve on, and we are finally, I think, going to deal with a lot of those mandates and testing, standardized testing. Kids are coming in crying at iRead. I do Read to Succeed, thanks to the Chamber and United Way getting together. I do that at Miller School every Monday morning, and I see those children come in and cry because they're afraid they won't pass that iRead test to go on to 4th grade. So we have to rethink some of the things that we're mandating, because it is causing stress not only for our children, but also for our parents and for you folks, because you're seeing that. I'm delighted to be here this evening, happy to answer questions. I do want to tell you that when I ask questions about monies directed toward prevention and treatment of mental health and substance abuse, I did have 81%. So I want you to take some of those papers. 81% said they'd pay a tax on cigarettes or e-vaping or whatever, you know, you would suggest. 81% said if we used it for mental health, that they would be willing to pay extra taxes for helping substance abuse and mental health. So you know how important that is. On the interim study committee this summer, we talked about mental health counselors. We have guidance counselors, folks, they don't have time. They're serving 500 kids when they're supposed to be serving 250. Let's face it, they're worried about getting the kids through school and into college, and the parents are worried with them. Dual credits now are offered. So guidance counselors are too busy. We have school safety resource officers, many of our police folks, gentlemen and ladies, work at our high schools, but our small southern small schools cannot afford that. So we're addressing that by equipping teachers to do that. We also are discussing at length mental health counselors in schools. That is, I think, a key issue to help our kids. The guidance counselors don't have time. You and I know that. They're just trying to help the kids stay in school and get their curriculum correct. And so I'm hoping that we deal with some of those issues. And Senator Brian Buchanan is here, so I want to give him a chance to get up here, because he's been very patient standing back here. Welcome, Brian.
Well, thank you. Now, Sheila, they told me to sit down there, to move down there.
Well, you sit wherever you want.
Well, I know. I just don't want you to think I didn't like you or something. They told me to move down here.
You
They
can be
can see
Ron
you better
Alton.
there.
Sit right there.
Ron's not here, so.
Okay.
Yeah. That's fine, Brian. We're glad you're here.
Okay.
Sorry.
Glad to see you, Brian.
Glad to be here.
I'm State Representative Chris Campbell. Just finished my first session, going into my second session. I'm very excited to be here. I represent District 26, and it covers the majority of West Lafayette, except for a section that Sheila Klinker has. It goes all the way up to the county, northern county border. It goes out to 500 West, and it actually goes down to 800 South. And it's also south of Teal Road, between Teal and Veterans Memorial Highway. So I cover a pretty big footprint of this area.
I have whatever Chris doesn't cover.
Well, she has
27.
Lafayette.
Right.
I serve on Ways and Means with Tim Brown and with Sheila. That was very exciting because so many of the bills go through Ways and Means because anything that has to do with money has to go through there. So I got to hear a lot of the testimony that other people didn't get to hear necessarily as bills were going through. I also serve on insurance and on government and regulatory reform. In addition to those committees, I am also on the Medicaid Advisory Committee, which is kind of separate from the legislation, but I'm a legislative appointed to that committee. So that meets quarterly throughout the year. So I'm really hoping to have some impact there, especially when it comes to our mental health issues. I know that has come up in that committee so far, especially when it comes up to as far as it relating to schools and things like that. So really looking forward to seeing what I can contribute on that committee. What else? I think that's about it. Thanks.
Thank you, Chris. Hi, I'm Tim Brown, House District 41, which is Montgomery and Boone County and one township in Tippecanoe County. I used to cover about 2/3 of the land area of Tippecanoe County and got cut down to one township. So represent much less of Tippecanoe County. I'm a retired physician. I'm chairman of Ways and Means, and so retired from practice of medicine to devote more time to budget development and the budget moving forward through the House. We are our own success as a physician. If you want your pain treated, we have ways to treat pain. If you want your anxiety treated, there are drugs to affect anxiety, and physicians are a part of this substance abuse development and growth that we've had. How many times have you been asked, is your pain being treated enough? And people want more. So we are part of a self-indulgent, I want treated, I want taken care of mentality out there as we move forward, and that has to change. Thank you.
Well, good evening also. My name is Don Leahy. I represent District 25 in the Indiana State House. That's parts of Cass, Carroll, Clinton. I live in White County, town of Brookston, and quite a bit of Tippecanoe County, the east side, eastern part, and some northern parts of Tippecanoe. It's a pleasure to be here to more than anything, find out what you're thinking. This is several of the, well, since I've started representing Tippecanoe County, so I've been able to attend here, and I've learned a lot from what discussions take place here, and what needs are in local communities and so forth, as I've talked to folks around the other parts of my district also. And so I'm looking forward to input from you, questions from you. As we look at funding, as we do every year, it's always an interesting to discuss funding issues with all elements of what state government gets involved with. And this is definitely a high priority, the needs here, and we're looking forward to dealing with that. So thank you very much for being here.
Good evening. I'm Phil Boots, Senate District 23, which comprises parts of Boone County, all of Montgomery, Fountain, Warren, Park, and Vermilion counties. You notice I left out Tippecanoe. I don't represent anything in Tippecanoe. But what goes on here impacts my area as well. I am on the Appropriations Committee in the Senate, Public Policy, Homeland Security, and Veterans Affairs, and I'm chairman of the Pensions and Labor Committee. And in the Labor Committee, we've oftentimes discussed workers' compensation or worker injuries and how those are treated. And so we've passed a couple of bills in the last few years that require physicians to treat injured workers differently than just prescribing opioids or some kind of pain medicine, but finding a way to treat those and try to keep them from getting hooked on certain drugs. So that's one of the issues that I look at and try to mitigate those impacts to people's families, et cetera. So I look forward to hearing from you all and trying to answer any questions.
Good evening. Brian Buchanan, represent Senate District 7, essentially reaches from Lebanon, I-65, all the way up to Rensselaer, so it does encompass a fair amount of Tippecanoe County. And I represent some very rural areas in Indiana, out in Clinton County and Carroll County and White County, and also some of the more urban areas here in Lafayette and parts of Zionsville as well. So I will say that the challenge of mental health and more mental health treatment services is real, regardless whether you're in one of those rural areas or if you're in an urban area. There's definitely a need. So I really look forward to seeing the conversation tonight, what you have to say. I think everybody recognizes there's probably still a need for some more mental health treatment services. It's just a matter of how we can provide those. It seems like also, in my opinion, the stigma is starting to break a little bit with mental health, and it seems like there's a lot of folks out there who have some mental health needs. I will say one of the eye-opening things for me was this summer when we're out some of the grand opening clinics. I believe it might have been the one in Delphi with one of the mental health treatment clinics, and was talking with some of the mental health providers there, and they're like, yeah, I'm one of the biggest users of mental health services myself because of some of the things they see and hear and listen to, and it hit me. I'm like, wow, I mean, after seeing all this and listening to this all day, I could see that. So it just was really eye-opening to me, and I definitely believe we need to try to get more services. The question is, how do we do that and do that in a fiscally responsible way? So thank you. Look forward to the discussion.
Okay, thank you. Okay, if I can get this going here. Okay, what do we hope to accomplish this evening? We would like to outline as clearly as possible legislative actions we believe would be most helpful to improve mental health and addiction services to those who most need those services. Not only here, but in the roughly 7 to 8 surrounding counties as well. To help that, we do have several handouts, and I hope everybody saw those, not only for your reading pleasure, but for your active participation. We have a legislative platform we believe outlines the most important legislative priorities. We also have a call to action, which gives you the information you need to contact your legislator, which of course they're sitting up here. Right? So you will have contact information as well as the legislative priorities for our specific area. Okay, the first step issue is the elephant in the room. And might I say, first of all, that elephant is...
Who brought that elephant?
That's the deal.
I'm just
And I
kidding.
gotta say, it's non-political.
Okay, you gotta have a
It's
donkey.
non-political elephant, so just want to let you know that.
Sheila, you want it down by you?
I noticed it was over there.
Okay, and that is Medicaid reimbursement rates. We recognize that this coming legislative session is not a budget year, so we realize that coming out here. But we also realize that earlier is better than later. You might say this is early budget intervention, I'll call it. So we've asked Zoe France of Valley Oaks to address an issue that has been a concern for quite some time and has such an extraordinary impact on so many facets of service to those with mental health and substance abuse. But it turns out it affects more than simply the people to be served. Zoe?
Thank you, Ken. Thank you, all of you, for being here. And thank you, all of you, for being here. So as Ken said, I have the honor of being the Chief Strategy Officer at Valley Oaks Health. For those of you that don't know, Valley Oaks Health is the community mental health center that covers the majority of your area.
Right.
So thank you to some of you who came to those open houses. I've also had the honor of being in mental health and addiction treatment for about 18 years, and I've been in it in a variety of different landscapes. And the one thing that I have seen, whether it be in the for-profit, not-for-profit, private, community mental health landscape, traditional outpatient, is that reimbursement has not changed for us for professional services since 1973. And for MRO services, it has not changed since 1993. So back in 2008, 2009, funding for mental health and substance use services was cut by 25%. And it has not been reallocated. It's just been moved around with no increases in 2008 and 2009. And so while rates have not gone up, overall inflation, as you know, has, with an average of about 3%, as well as our salaries, because as you can see on the chart here, to keep up with the need, we've had to get competitive with workforce, and you will fall off your chairs when I tell you about psychiatry and that expense to get psychiatrists to come to Indiana here in a second. And so 2 areas that I'm going to focus on are all shortages. We're identified as mental health work shortage areas in pretty much all of the areas that you represent. So when you look at the map, if you want to go on HRSA's website, we are bright red as far as mental health workforce shortage. And so 2 of those areas, though, that I'd like to focus on are master's level social work / therapist, and then also psychiatry. Now, the good news is that we have done a lot of work as a community to bring nurse practitioner program to Purdue, and Purdue has done a phenomenal job. We're looking at about 12 graduating, so that's going to help some on the med management side. So there is some good news and some good work that's been done. But for therapists, and you can't see this chart, I'd like to pointed out, but the need back in 2016, therapists were 41% need. And so with all the work we've done for therapists, we have only been able to meet 16% of that with our workforce. And so there's a lot of reasons for that, but just to kind of put it in perspective, because I am an MBA by background in operations, and so for me to hire a social worker, you're looking at, with experience, a license, at benefits, you're looking at a total cost from an agency standpoint of around $92,000. So reimbursement with Medicaid is right around $71 per hour. If you were to gross those hours that can be billed for a year, you would earn right around $85,000. Well, the math doesn't add up to me. That is a loss of $7,000 per FTE that we're losing to provide that service. Now, psychiatry is a little bit more startling. Our average comp has gone up quite a bit, especially in this market, to be competitive. We've done a great job responding with psychiatrists. You can see that the red and the blue are lined up a little bit more, but we had to do that with salary. With benefits and all other costs, you're looking at a total of over $400,000 to pay for a psychiatrist. You guys know what they earn on an hour rate? $138.29 with an annual collection of right around $165. So we are losing over $300,000 per doctor, but we need them for access. So Valley Oaks has 18 providers. So you analyze that out of what that loss is operationally for us. It's really not sustainable. And so as we're looking at that, both of these rates fall within professional services, which has not been increased since 1973. So what has been a result of this lack of reimbursement, because often I hear, well, we can't get people in, we call you, you're on a 6 to 8 week, believe me, as a provider, we want to serve everyone that we can, but we have a workforce shortage. And so the other thing that has been impacted is that our turnover rates with burnout, according to a Pew Charitable Trust study, because of that lack of compensation and the work, like Brian was saying, is hard work to do. That burnout is very hard. And then you're also going to hear from Stefka in a minute regarding what the cost is to even be a therapist, which when we added that up, to even be a therapist, it doesn't pay for itself. Prevention efforts are not covered with any reimbursement. I was just at a public policy meeting in Indianapolis, and we were talking about the importance of prevention, and it relies solely on grant funding. And while grants are great, my biggest thing with grants is the sustainability. And continuing the sustainability.
Yeah.
So as an agency, what is that vision as a strategic person looking out 5 years? What is that going to look like if that grant is not there? And I don't want to be the provider to start something and not be able to support it. And so without workforce and prevention, an access issue has now been created. Each of us in the room who provide outpatient services, we have a wait list around 6 to 8 weeks. And I know, having someone who suffers from both mental illness and substance use, that 6 to 8 weeks is too long. When I need help, when that family member needed help, they needed help right away. And so what happens is they go to more of an acute state, which then costs more money in the long run. And so we're very reactive in that approach. Our recommendations as a local legislative group is we really would like you to prioritize funding and resources that promote early intervention and treatment in early child care and education system. And then also there's this wonderful, beautiful thing called parity. And parity happened back in 2008. And parity is to not discriminate. And so whether it's heart, diabetes, flu, or mental health, it should have the same access. And that is really, we talked about this at public policy today too, that should include all of the managed care organizations as well. It's imperative for the Division of Mental Health and Addictions budget to be increased for both mental health and substance use treatment services. We did, and we thank you for seeing the grant money for opiate use disorder, but the funding was restricted for opiate use disorder only, and it's very short time frames. And so I have the honor of working with Jason at Phoenix Paramedics, where we have this phenomenal peer program. Well, we have that grant funding for another year, and the thing that keeps me up at night is what's going to happen after that year to be able to connect people. And we've seen, as a result of that program, overdoses, ER visits, and jail recidivism go down because of the work that the peer program has done in our community. So what are we going to do to sustain that? The rate that Medicaid put in for a peer, it's varied like $10 and roughly $10, $11 per peer. So that reimbursement doesn't really help with the overall operating cost. And so we also, like Indiana Medicaid and the licensing IPLA, should access rates for counseling services and substance use disorder and mental health through the Certified Community Behavioral Health Clinic model, which Indiana applied for. So I have good news that it passed through the Senate Finance Committee on a federal level. And so if we can be that voice with Medicaid to say, this is a model we would like Indiana to do. The 8 states that have piloted this program, and again, if you want to know more, it's CCBHCs, and they have seen their ED visits go down, they have seen emergency room, they've seen their jail recidivism go down, and it's a clinic model that's based off of value-based care and support, and so those metrics really impact the local community. And so we are one of the 11 that is up, so if you hear that on a local level, please be championing that. And then we also need to compare our rates with other state Medicaid programs and private payers to determine what increases are needed. At the very least, a 3% annually increase to keep up with inflation and other expenses is needed, because having rates since 1973 is making it very challenging and creating an access issue. Any questions for me?
What's the success rate of some of the programs for substance abuse treatment?
Well, the success rate with the peer program has been extremely high. There's been, percentage-wise, I know totals per month, but I would have to add up for a total since we've had that program as far as getting people into treatment and on the road to recovery. But Jason, do you want to?
With the individuals that, this is just off the, shooting from the hip, I don't know the exact numbers, but with the individuals that we encounter, we're getting at least a 50% initiation into some type of recovery support service or treatment. And that's about 100 individuals per month in Tippecanoe County, 15 in White right now, and just under 15 in Jasper. Just expanded into White and Jasper County.
I'd like to react to what Zoe said about reimbursement. There was an impact room that was added to the emergency room at Franciscan Health, and I know many of the folks from emergency are put in the impact situation with 4 nurses there. Sometimes it's online psychiatrists that are working with them. They have not been reimbursing those folks in the impact. No reimbursement yet, along with DCS folks, workers, who have, some of them not been paid, September, October, November, some 2 months. They're calling us, telling us it's Christmas, we have to be paid. Private contractors are calling us, saying they're not getting paid. I know it's a new reimbursement system, and we have to be patient. The people that I called at the state office, I have to say, were very kind and saying they're looking for a way to get those folks paid, and hopefully next week they will be. So they are working. It's not that they're ignoring this. But there have been cuts in some of our plans for the future. The Healthy Indiana Plan for 2021 is maybe losing $16 million. The Child Psychiatric Services Fund, that doesn't mean that we won't address that. It's about $36 million now, but supposedly it's going to lose about $9 million in 2021. Seriously mentally ill, over a little $8 million difference. Now that means that we will address that in the new biennium. But as you mentioned, and as Chairman Brown will tell you, sometimes we do appropriate more funds the second year of the biennium, but it's usually kind of an emergency basis on what we're seeing happening in the state. So I'm hoping that we address some of those issues that you mentioned, Zoe, and address the need, because our case managers are so good and they get paid so little, and they go in very difficult situations in homes with opiate abuse, foster parents that maybe are not sure how they should be treating their children with different difficulties. So I'm hoping that we look at some of those issues that you have just mentioned.
Absolutely. So I'm going to turn it back over to Ken. Thank you. Yes?
Well, I just had a question off of Representative Brown's. He asked what the success rate was. How in the mental health treatment business do you define success? I mean,
Well, for me, it's keeping people out of our judicial legal system. It's for me having them in a walk of recovery. And it's also keeping them out of the emergency room and in the acute state. So, there's many of us in this room that, will see a therapist, probably for life, or have a peer through NOMNI, whatever that might be. But it's really to define that they're in treatment and that they're successfully completing treatment. That's success for me.
Thank you, Zoe. The second issue for this evening is workforce development, which includes both adding professional staff as well as enhancing the skills of current professional staff. Like so many companies and organizations in our state, these organizations serving those with mental illness and addictions are limited by the ability to add appropriate staff. While solving issue number one, which we already talked about, would help, certainly would help, we believe there's some other things that could be tweaked by the state that could assist our providers. We have asked Stefka Paulette of Meridian Health to present our thoughts on this issue.
Okay.
Good morning, everyone, or good evening, everyone.
Good evening. It just seems like morning. A long day.
It's only Monday. So like Ken said, my name is Stefka Paulette, and I am the practice manager for Meridian Health Services Addiction and Recovery Center. We're located inside Riverbend Hospital in West Lafayette. I also have my master's in social work. I'm also a licensed clinical social worker. I have a certified alcohol and drug counselor supervisor certification, and I also have a medication-assisted treatment specialist certification. I'm going to share with you some insights about what it is like to become a licensed clinician by sharing some of my story. Being in the helping profession is not something that I ever grew up wanting to do. To be honest, I didn't even understand exactly what a social worker did or how important they are for our community. I became a licensed clinician after achieving my dream job of becoming an airline pilot.
How about that?
Many people are taken back at why I decided to leave such a prestigious and well-paid profession. During my time as an airline pilot, I was privileged not only to fly with some of the most dedicated and professional people in the world, but I also was privileged to serve them. I volunteered to serve my pilot peers through the union's version of an EAP program called the Human Performance Committee. I worked with peers on such things as accidents and incidents, FAA investigations, divorces, marriage counseling, physical and mental health concerns, and substance use issues. Through this work, I learned there is more to life than gracefully landing a heavy aircraft in challenging weather. I learned that being in service to others was my true calling. My dream job at my dream airline suddenly ended when the airline I was working for ceased operations, filing Chapter 7. Which is also known as liquidation, so there was nothing left. So given my six-figure income and learning to budget and save, I was able to go back to school and obtain my master's in social work. Although my story isn't exactly what most clinicians experience, most enter the profession with the same desire, to be in service to others. This desire to be in service in our current environment also means an acceptance of compensation that is very similar to those people that we serve. Meaning entry-level wages are between $18,000 to $23,000 a year. I'm here tonight to talk about the state of our workforce and our ability to provide services. At Meridian's Addiction and Recovery Center, we are ready to expand our services. We are currently waiting for our Medicaid certification to start our outpatient treatment. We have one licensed clinician to run that program. If we want to add more groups and more therapy options, we need to have more licensed clinicians. We currently have a 16-bed residential unit. We're remodeling and I'll be able to add an additional 16 beds in January. This will give us the capacity to offer 32 residential substance use disorder beds in our community. But we need more staff to be able to provide these services. Within our community, we have numerous service providers. But one of our biggest barriers isn't having a space or a location to provide services, it's having a skilled workforce to do so. So let me explain some of the financial burden to become a licensed professional. So we all have to have education. So first you have to have a bachelor's degree. And I looked into Purdue, and if you were to graduate today from Purdue with a bachelor's in psychology, it's going to cost you $23,000, which is pretty good. Because we know that Purdue has worked really hard at keeping the tuition rates down and consistent. But $23,000 is a lot of money. So you don't only need a bachelor's degree, you also need a master's degree. So if you were to graduate today from Indiana University with a degree in a helping profession, that's going to cost you $93,000. So the total cost today to obtain the required education for a licensed clinician is $116,000. Remember, those entering the helping profession understand that they're not going to be hired right away making six figures. They accept that. They don't want to become rich serving people. However, they aspire to earn a wage that will support themselves and their families into the middle class. So an initial investment in becoming a helping professional is going to cost you around $116,000. So next, not only must you meet the education requirements, you must also meet experience and licensing requirements. And this starts with obtaining a beginning license, which identifies you as eligible to earn the experience with the support of other licensed professionals. In the flying world, we would call this, you now have a license to learn how to be a clinician. After obtaining this experience with the support of other licensed professionals for 2 more years, you become eligible for your clinical license. Insurance will often only pay for the clinically licensed people and not somebody who has a beginning level license. So licensing. First, you have to apply through the Indiana Professional Licensing Agency. We call it the IPLA. This includes a licensing packet, which includes a $50 application fee. Got to get your fingerprint and your background check completed, and that'll cost you between $90 and $100. And you have to get verification of that education. And remember, we paid $116,000 for our education. A passport photo, and then you also have to pass a written exam. So the written exam is a whole process in itself. Most people who take their written exam, they prepare by taking a prep course, whether it's in-line or on person. And that runs you between $300 to $500, depending on how much you're willing to invest. And the cost of the exam is around $500. So you will also need to take a day off of work to go take your exam. And if you're lucky, you take some time off from your work to be able to study for the exam. So the total cost of just getting the exam done, you're looking at around $1,000. So after you submit your application, which is only allowable via snail mail, the old-fashioned way, your total cost for applying for your license and getting that license is $1,150, which allows you to be eligible to work for 2 more years at that beginning license level, making $18,000 to $23,000, to be able to earn the experience to become clinically licensed. So clinical license, that is very similar to your entry-level license. In addition to the application fee and the fingerprint, background check, passport photo, and written exam, remember that all cost us around $1,150, and then the verification of our education, which is $116,000. We're now looking at, so far I've invested $117,000 into myself becoming a licensed professional. But now I have to add the supervision component. So supervision is what we call the support from a licensed professional you must have obtained for the last 2 years. This supervision must be from a licensed professional who has a current active license. If you're not fortunate enough to work for someone who offers this, you have to seek it and pay for it on your own. The average cost for 1 hour of paid supervision is $100. You must prove you have 100 hours of 1 hour per week, in person, face-to-face supervision for your clinical license. So if you do the math on this one, the cost for supervision for 2 years at 100 hours is $10,000 for that 2-year period. So now the total cost for becoming a licensed clinical professional, including the education and the licensing fees and the supervision experience, is $127,000 and some change. So the whole process of becoming eligible to bill for your services to an insurance provider takes a lot of time, effort, and financial means. Entry-level professionals enter the field upon graduation with an understanding of the licensing process and seek employment based on where they can obtain a livable wage to sustain themselves and their families during this time period. Most entry-level employment opportunities are available in the nonprofit arena. Most nonprofits are dependent on Medicaid, and as Zoe described earlier, the reimbursement rates don't meet the operational cost. As a service provider, you invest in an entry-level clinician who you know isn't Medicaid billable and hope that they will stay with you long enough to become Medicaid billable. Therefore, it makes sense that the nonprofits can't afford to pay more than a poverty level wage for someone who they can't bill for. However, if we don't give entry-level clinicians opportunities to practice and gain their experience, then we won't have licensed clinicians to bill for and meet our bottom line. So as I've shared, becoming a clinically licensed professional is not easy with a heavy financial burden. I'm going to remind you again, that's $127,000. We enter the field with a naive acceptance that it's not going to be this way forever, and gain satisfaction from seeing the people we serve actually make achievements in their quality of life. Over time, we become burdened with enormous caseloads, poor work-life balance, and a wage that doesn't compensate us for our sacrifices. The end result is a declining workforce and less experienced clinical professionals to train the next generation and provide ongoing services. One barrier we can address right away is the cost of education. If we expect people to invest in themselves and engage in ethical practice, we need to provide them an opportunity to succeed. We do this by making education affordable. So I've talked a lot about the minimum education requirements for licensing. Remember, that was $116,000 for my bachelor's and my master's. The current loan forgiveness program is only a program by name. It is not funded to provide forgiveness for everyone who is eligible. The requirements for eligibility are also next to impossible to meet and not equal for all. For example, currently, according to the National Association of Social Workers, I'm going to explain the most recent up-to-date student loan forgiveness options. So the first one is the College Cost Reduction Act of 2007. This program discharges any remaining educational debt after 10 years of full-time employment in public service, including government and nonprofit agencies. You must make 10 years of full, non-reduced loan repayments without missing even one. You also cannot be a supervisor, so you have to be a direct practice clinician. You cannot be a manager or a supervisor. And the loans must be only through federal programs and not private institutions. So there is another option for student loan forgiveness, the National Health Services Core Loan Repayment Program. This program is for licensed clinical social workers only. So remember, to obtain a licensed clinical social work license, you must have a total of $127,000 and some change upfront, and work at wages of $18,000 to $23,000 for 2 years while making all of your student loan payments in full and on time. This program will give you $50,000 in student loan repayment in return for 2 more additional years of working in a community-based site in a high-need designated health professional shortage area, which is always suggested. That's right where we're in right now. So for the clinician, this translates into working at a low-level wage with an unmanageable workload, poor work-life balance, and no guarantee that the program will be funded after you complete the 2 years of service. This program requires you to live in poverty without saving, using the services you advocate for your clients in order for you and your family to survive. And there's one last that I feel like this is the most insulting. So there's the Higher Education Act. This act was first signed into law by President Lyndon Johnson to help encourage and support our citizens with continuing their education. It has helped to fund our federally administered student loan and institutional aid, and it also advocates for inclusion of minorities into the federal aid. Most recently, it included loan forgiveness provisions. However, the loan forgiveness provisions have never been funded. So education is really important in providing a highly skilled workforce. We also need to provide a work environment that is supportive and pays a reasonable wage. We often have our first challenge to our desire to save the world one person at a time when working through benefits with our clients. A common first experience when working with clients using the poverty guidelines is realizing that they had way more income than we did. Next, we realized that our current wages of $18,000 to $23,000 were below the poverty guidelines. Then finally, we realized that we qualified for most of the services we were referring our clients to. This comes from many of the issues that Zoe has described with service providers not receiving a reasonable reimbursement for the services they provide. You will also learn from Jenny and Lisa Marie the details of the administrative burdens and providing services within the school systems. So to wrap it all up, we enter the helping profession because we have a strong desire to make our communities a better place. We need support in obtaining our training, education, and a work environment that sustains and rewards us. We need wages that allow us to support ourselves, our family, and the ability to retire. Remember, the people who do this work enter the field with a desire to be in service to others. It seems reasonable. If we provide an environment where they are healthy and supported, they will be successful, and our community will be too. So,
Very
any
good.
questions? I know that's a lot, but it's all doom and gloom. We do this because we love it, and our heart is into this. But we need some help to get more people to come do it. And I have a bunch of my interns here to see how policy works, or master's level interns. So we're keep bringing them up.
How many interns are here?
I saw 3 of them. And then you guys brought a
Great.
friend?
Oh, good. Thank you for doing this. That's great. And what will they be starting at, 23,000?
Yeah.
And how do they get ahead quickly? By getting another degree?
That, looking for certifications that don't require a master's level.
Okay.
So like a peer certification, a licensed addictions counselor that don't require you to have a master's degree. But reimbursements aren't so great for those either.
Can I-
Yes.
So do you have suggestions on how you can streamline or reduce the requirements? Or is that something you think should happen?
I think the requirements are great. It's when you enter the workforce, you have to have hope that you will make an income where you can pay off your debt.
We just went through that.
And I'd like to warn you that that's what they did to, so I have an undergrad in speech language pathology and hearing, and I'm an audiologist, and I keep bringing this up because the streamlining, when they found shortages in finding providers for these rural areas or areas where they needed help, they decided to go with the bachelor level. Now, think about that.
Yeah, it's
Your
not-
profession is the same as ours. It's pre, we get anatomy and physiology and then, all these other things that we need. And then you actually learn what you need to do your profession in that master's level and that clinical year experience. That isn't covered and they can't be streamlined into a bachelor's degree. I was so stressed when I started my master's degree, and I was an honor student in my undergrad, and it was plenty for me to do. And these people will have very similar undergraduate programs. These are pre-medical degrees. You can't streamline it and cram it into a bachelor's degree and then expect the same level of service and care, because there's just no way to put all that information into a bachelor's degree.
And she's dealing
And
with
clinical
verbal
year.
and hearing.
So, yes. And, and an audiologist is now a doctoral program.
Right.
And we just passed emergency licenses for people to be audiologists with an undergrad degree. So, yeah, let's not go in that direction.
I honestly believe I've worked with interns for numerous years, and I do that as part of my way of giving back to the profession. And the amount of learning that happens during those practicums in your master's degree is huge, and it really prepares you to be able to earn that beginning license so that you have that support to become that licensed clinical professional.
And you need that foundation of that undergrad to be able to learn the rest of it. We really need to know the parts of the brain and the physiology and all that other stuff before we can move on to that next level. And we learn more in graduate school.
Well, it's like teaching without student teaching. And it's not quite like, working with your ears in healthcare, but working with children, you need a year rather than, and they're going to stretch that student teaching to a year rather than just a few months, because they found that that is needed to prepare you. So I don't think we want to lessen.
No.
I think we want to pay for people being able to have the expertise, just as, Dr. Tim, who worked in, emergency as well as family practice. We wanted him.
I'm sure he doesn't want a
to be-
pre-med student doing the job that he was doing.
Right. We wanted
in
him
his
to be
undergrad.
prepared, and work with people. So I don't think you want to streamline these things when you're working in this area, which is extremely important.
Absolutely. Anything else? Thank you. I'm going to hand it back over to Ken.
Okay, thank you, Stephanie.
That's right.
Okay, we have two more issues to go, just to let you know. The third issue is an area we've seen some progress over the past couple of years, but it continues to be one that creates obstacles in our goal of serving as many people as we possibly can, what I'll call artificial administrative burdens. Willowstone Family Services Executive Director Jenny Murtaugh has agreed to address this important issue for us. Jenny?
Thanks. It's so nice to see everybody here. Thanks for being here and paying attention to this issue. Unlike Stefka, I grew up saying, "Mom, I think I want to be a social worker." And she said, "Oh, honey, no, you'll have every kid in the world living with you. So I have a degree in business administration.
That's good, Jenny.
But with 20 years of not-for-profit administration work, I've been the executive director at Willowstone Family Services for a little over a year and a half. I pride myself on compliance and being a quick learner, and I have learned so much about how to provide high-quality mental health services alongside of prevention, because we can never forget prevention, while still being Medicaid compliant. There are several things I have come to understand create additional costs in providing billable service for Medicaid that other insurances just don't require. Keep in mind, different types of providers receive different rates of reimbursement from Medicaid. Willowstone Family Services does not have a psychiatrist. That is really pie in the sky for us. We do have 7 therapists. 6 of them are licensed, and we're always trying to bring one up through the ranks. She's soon to be licensed next year. But we have, as a small private counseling clinic, Willowstone receives the lowest rate of reimbursement for counseling from Medicaid, and that covers about 47% of what it actually costs to provide an hour of therapy. So we do struggle to pay therapists what they can make elsewhere. And this is why many private providers do not accept Medicaid. So with the help of United Way funds, Willowstone's grateful that we're able to serve Medicaid clients to align with our mission and values, to keep services, mental health services, high quality and accessible to the community. But there are many standards that, if simplified, would make care more accessible to Medicaid recipients and then help those local resources stretch even further. And I won't talk about them all, but there's a few. First point is that Medicaid requires supervision from a psychologist. This is expensive to provide, and none of the other 20-plus insurance providers that Willowstone accepts requires this. Luckily and thankfully, HEA 1175 passed last session to eliminate this requirement. We hear it will likely be the first or second quarter of 2021 before therapists will actually be able to sign their own record for billing. So we're happy it's coming. We are very grateful. It is a light, but sooner rather than later would be very helpful in reducing expenses that truly are not covered by the reimbursement rate. Tagged on to that is that, as Zoe mentioned, those 12 psychiatric nurse practitioners who are graduating, it would be great if we could do a similar thing for them so that they too could practice independently without the supervision from a psychiatrist. That would broaden accessibility, as psychiatrists are really hard to come by. Again, referring to the chart, we've made progress, but really utilizing the information that people learn and the license that they hold optimally does impact accessibility. On a broader scale, and this is just Jenny's little side note, all Medicaid therapy notes must include very specific, lengthy documentation to ensure proper treatment. Other insurances do not require anything close to this level of documentation for therapy sessions. We feel the management of care, this level of management of care is unnecessary for master's level licensed clinicians who have worked so hard to get that license. This creates micromanagement of sessions that often to us seems counterintuitive to quality care for mental health. Next is the credentialing process for licensed therapists. For a small clinic like Willowstone, each of our 7 therapists must submit information and sign contracts and wait for each of our 5 individual Medicaid insurers. It's really actually 15 if you break it down by type, to approve the therapist as a provider for Medicaid. So while they're waiting to be approved, their therapy is not reimbursable. On top of that, we sign as an organization an agreement with Medicaid to be a Medicaid provider that says I can't provide that service to a Medicaid holder using any other funds. So hold on, wait, and don't let that person work until we say go. So not only is this an investment in unbillable time with each therapist hire to get them paneled with Medicaid, we are unable to provide those services using any other funds. A change to a centralized or one process for all that stays with the therapist when they go, and provisional credentialing to fill the gaps in time would greatly reduce the cost of onboarding new therapists and keep their services available amidst a transfer of location or employer. So if I bring a therapist on board and I'm working really hard for 6 months to get them paneled with every Medicaid provider so that we can be reimbursed and they can treat Medicaid recipients, if they say, oh, I can make $10,000 more a year over here, and they leave, they go to that person and it starts all over again. So we're really not optimizing their time. Another example of a burden in Medicaid states that they will pay, Medicaid agrees to pay us within 60 days of a bill. But if they overpay, they decide something doesn't align right, and they want that money back, we have 30 days to turn it back around. And sometimes they just pull it back out of the bank. So it is difficult to manage. Sometimes we know how much money we really have.
That happens to a lot of people, too.
So this committee supports strategies to relieve the administrative burden for Medicaid. Provisional credentialing, a one-stop shop for credentialing providers, a prompt payment statute, a written process that will have oversight and accountability for providers to get paid for the work they do, and evaluating the status of advanced practice registered nurses to allow them to practice independently. Thank you. I hesitate to ask this, but do we have any questions?
I just have, I don't know enough about what you're talking about, I guess, but are these federal requirements or these state requirements in Medicaid?
Well, there are some that are state, so some of them are federal, but the ones that we have outlined
Ones you're outlining are
are
state.
specifically things that we can impact at the state level.
Good.
Thank you.
I agree.
Thank you.
Medicaid for, yeah,
It's frustrating.
yes.
How many times I've said, oh, that can't be right, let me see that.
I know, all of the
Yes.
documentation that goes with any Medicaid, getting patients hearing aids, any speech therapy, anything, is so much documentation. I can't imagine how it got there. And who's overseeing it? Is there somebody that knows what they're reading it?
It clearly is a progression that has happened over time.
That's right.
Yeah.
And responses to
That's
certain
right.
problems, but
Exactly.
we need to understand what it is today and see
One problem brings another
what we can do to make
along.
those reimbursements that are already low at least manageable.
Yeah.
So thank you.
You brought up,
Back to Ken.
Hey, I'd like to
Stop
ask a
shopping is
question.
really-
Oh, I'm so sorry.
And not necessarily for you to answer, but maybe someone else. You provide services, and we talk Medicaid mostly. Is there any, do your providers provide services to like private pay? I mean, is there other sources of?
Absolutely. So we
So it's
accept
not-
Medicaid, Medicare, HIP, and 30 other private insurances. So not everyone I serve, and I offer a sliding fee scale for underinsured or uninsured people as they're able to do that. So if someone has a private insurance and they have a copay and they can't afford the copay, they can ask us for help with that. Thank you, United Way.
Okay, thanks.
Jenny, your background in business administration and other issues has helped all of us. It helped us with Right Steps when you were with Tippecanoe County Child Care.
Thank you.
But we appreciate the fact that you've suggested some solutions, and hopefully we'll look at
It's
those.
a whole team
Yes.
of folks. They have taught me so much.
Yeah, thank you.
over the course.
We appreciate that.
Okay, thanks so much, Jenny. One final issue. Okay. Our final issue is early intervention.
Early intervention.
Roughly one half of all mental illness develops by the age of 14. One place that nearly all young people attend is school. So schools will be an ideal place to help identify emotional behavioral issues so they can be addressed early in their life. We've asked Lisa Maria Lucy of Willowstone Family Services to speak. I normally butcher her name, but
You did good.
yeah.
You did well.
It's hard when you have 3 first names. You know. So the good news is I'm the last one. That's also the bad thing, right? So as Ken mentioned, I'm here to talk about advocating for increased mental health access within our schools. So as Ken mentioned, I am the Director of Clinical Services for Willowstone, and I'm a licensed marriage and family therapist and also a licensed clinical addiction counselor. So that basically means I'm a therapist. And over the course of my career, I've worked in multiple settings, including the school. So during the last legislative session, there was mental health legislation that was in the process to be passed to help increase access to mental health professionals in our schools.
That's right.
While the legislation passed, some important provisions were removed due to concern of parental consent for treatment. So I'm going to talk a little bit about that.
Oh, yeah.
I want to assure you that there are several rules and laws in place that make it mandatory for mental health professionals to obtain a consent to treat a client, or we lose our license, which would, in essence, end my career. And I like my career, and I don't want it to end. So you can count on me to get that documentation. So mental health agencies have implemented their own internal policies and procedures to work within the school settings to ensure that we obtain permission from parents before we work with a student. The policies and procedures, they vary between different mental health agencies on how to obtain the consent to treat, but every agency must obtain one before we can work with a potential client. So at Willowstone, we are currently working at McCutcheon High School to provide on-site therapy to remove some of the barriers towards treatment. So the following are some of the steps that we take to ensure that we have consent on a continual basis. So at first, the school will identify a client who needs therapy. Then the school reaches out to make the first contact with the family to see if they're interested in counseling. If they're interested, then Willowstone reaches out to the parents to discuss what counseling is and if they want to participate. Then, if they agree, the family and the therapist meet in person to fill out the consent to treat paperwork and to make an agreement that Willowstone will work with their child for 6 times, and then we'll meet again and have a family session so that we can talk about what's been going on in treatment and to make sure that we're still on the same page about what we want to do. And then we'll go again for 6 sessions and then repeat the cycle until the problem has resolved. We're currently in the process of trying to work with some of the elementary schools to provide the same kind of treatment. But elementary schools are a little trickier because they're little people and little kids need more help from their parents, right? So we're trying to find ways to still, after the consent is obtained, to get parents into treatment on a more regular basis. And that is a barrier. But we're working with several schools to try to reduce that. So we really want to make sure that we are meeting with the parents so they know what's going on and we can have continuous consent. So another aspect of the legislation that was discussed was the social emotional learning. And I have an example for you. And it's kind of simple. Tim, you can please correct me if I'm wrong. So you go to a doctor and she tells you that you have prediabetes. And she decides, I'm going to give you metformin, which is a medication to help you hopefully not get diabetes. So this is prevention. That's hopefully cost effective so that you don't get diabetes, right? Because that could be very expensive. Well, when you teach children in elementary school how to manage their feelings, teach them to calm down or communicate better, you are helping to decrease future behavioral issues. The earlier you teach social emotional skills, the better. It's cost effective. This is prevention work that does not need parental consent versus mental health treatment, which is the counseling and the case management that does require the consent. So I know several teachers that are already incorporating these skills into their classrooms. But can you imagine the impact we could have if all teachers incorporated them and that we had funding? So anyways, thank you, and we appreciate your continued support of mental health services within our schools. Thank you for listening.
Very good.
And I'm not going to ask for questions because I know Ken is.
Well, let me just react. I think preschool, pre-K,
Right there.
on the way to pre-K is really important, and a lot of these services are offered through that. And we are in 20 counties now, and hopefully we'll be in all of the state of Indiana, because your services would be very much a part of that pre-kindergarten program. We appreciate what you've said. Thank you.
Thank you, Lisa. Okay, now it's your turn. And we're interested in any thoughts you might have. And we started with Sheila the last time, so I'm going to flip the
Start with
table
them.
and
Good.
start with Brian.
Yeah, well, I was going to ask a question.
Oh, okay, you can do that.
Yeah, sorry. Can you walk me through, you said with students and mental health counselors, if they're identified as conversation 1, 2, and 3, how are those students initially identified for potential mental health treatment?
Sure. It depends on, like, if they're in elementary or middle school, they're acting out.
That's a good question.
They can't focus on their tasks. They're hitting their peers. They seem sad. They seem withdrawn. There's a lot of different symptoms that teachers can see.
Throwing things.
Teachers are really in tune with their students, and they can know when something's wrong. So usually that, poor grades, missing school a lot, being disrespectful. All of those things can be indicators that that's just the tip of the iceberg. That just gives us more clues that we need to investigate more and see what's going on and try to help them with more coping skills and helping them with trauma if there's trauma.
Okay, great. Thank you very much.
You're welcome.
I was just curious because I know this was a fascinating conversation last session, and one that I serve on the education committee and a lot of discussion, and it seemed like the ultimate conversation came down to mental health treatment and parental rights, and where does that intersect? Because I'll be honest, as a parent of a first grader and a preschooler, if my kids need mental health treatment, I want them to have it. But I also want to be fully involved and engaged and knowing what's going on. So kind of trying to find that intersection there. So
Yeah, and if an outside agency is helping, and we do work in the school, you're going to have a consent. We're going to have lots of conversations about what's going on in care, and we want you to be involved in care. There should never be a time when you're not involved. So I get really confused as to why people say they're concerned about consent, because You can lose your license in a heartbeat.
And you bring up a valid point by that, by losing your life. I just know, I hear that especially in peers
Sure,
and
it's
friends
scary.
and friends and colleagues and all that kind of have kids in the elementary level or whatever. But yeah, thank you for answering my question. I appreciate
You're
it.
welcome.
So, now I'll answer your question, I guess. I appreciate the dialogue, appreciate the information. I think a lot of good points were brought up this evening as far as essentially more mental health treatment, more accessibility. How do we get that? And to me, it seems like the one kind of common theme is less regulations and more funding. And I don't know exactly how you do that. I mean, I know as the state government, we're asked to fund a lot of things and do a lot of things, and it's kind of a balancing act. And I say in everything we do, we still got to maintain a fiscal responsibility and do it in a prudent way. So I look forward to more discussions with my colleagues, and we'll certainly keep working on it. But definitely, I hear your concerns and your issues. Thank you for having us.
Well, I too appreciate the dialogue and the information because I'm not well educated in this area, as you probably know. I'm a believer that, when you talk about elementary school kids and junior high kids or whatever, I think parents are probably the problem, not the kid. So I don't know how you want to treat the child, but it's the parents that need the treatment, and the parents don't think they have a problem, so they don't think their child has a problem, so I don't know how you're going to get parental consent. So I think that's a conundrum that you're going to have to work out. I think if we can fix the family, we can fix a lot of problems in our education and our world today with addiction, et cetera, et cetera. I don't know how you do that.
The earlier, the better.
Well, the earlier better, but you still got to get to those parents, and the parents don't feel like they have a problem. So in many cases, and they're raising children that are going to be a problem for society for the rest of our lives. So, I appreciate that. I wish we could figure out if you had solutions for that one. The other thing, I still believe that there's got to be ways to get more people into this profession and providing some services. I know we got advanced practice nurse practitioners that we're now allowing to do more stuff without direct supervision, et cetera, and I don't see why there can't be the same thing done in the mental health area as well. So I appreciate the wherever she went, that has, ideas on how we can fix Medicaid reimbursement or the rules and regulations that they throw out at us. So, I certainly have enjoyed listening to what is going on. I can't say that I enjoyed what I heard, but I can just say that I appreciated the dialogue and the information. And so obviously there will be more discussion. I know we had discussion on how we can get schools more reimbursement from the federal area as well by doing some of this mental health thing, and I know it didn't go anywhere, but it's still a discussion that we're having, and we'll move forward. Thank you.
I'll be there in a minute. Also, I appreciate, first of all, were your comments that you presenters made this evening, I've tried to take notes, but I'm slow and I can't write very well. Will those kind of be a synopsis or a bullet points of the comments made tonight from the presenters that would be available?
I'll get that emailed out. I have them. I have all the comments in writing.
Okay, all right, that would be very helpful for me, I know. Something else, I asked about services that you may get from private pay or other sources other than Medicaid. Is there services there, or is there funding available there through the schools? Is that ever been pursued as far as if you do have a program like you mentioned McCutcheon? I think someone mentioned McCutcheon.
So for Willowstone, because we have licensed therapists, we can take private insurance and Medicaid to work with the students.
Yeah.
Oh, but she's right. It costs us a lot of money to do that because we don't get paid for drive time, we don't get paid for.
It's actually lost time for therapy because of the management with the school. So I estimated when we started to do it, and because we have fundraising and other flexible funding, we just feel like it's the right thing to do, to remove those barriers. But after now, we've done it for a full school year, and we're doing it for our second year, it's costing us more than I estimated.
And then Valley Oaks model is a little bit different. We have a school-based team, 2 of our team leaders here, and so we provide case management services in all of the counties that we serve, but it is for Medicaid only, because Medicaid is the only one who provides case management reimbursement. The commercial insurances do not. So it's a very different model in that way. It's case management, life skills development. So yeah, and the only other funding that we've had is grant funding, which isn't sustainable. I just finished using a grant that was awarded to us in 2014 that was supposed to originally be for substance use treatment. The schools in Glass awarded it to TSC, and LSC awarded it to us through Glass to treat kids within the Tippecanoe County that had substance use. We couldn't identify under the parameters of the grant those kids, so then we were able to move those fundings with their permission to treat kids with life skills and other mental health issues. But as I said, it wasn't sustainable. That ended in May of this last year, and we haven't been able to find funding to then reach those kids who don't have Medicaid, who don't have private insurance and things like this, those kids that are lost in between, that those parents aren't necessarily able to pay for these services and stuff. So it is a very underfunded and needed service for these teens and these kids, whether they're preschool through teenagers, going into adulthood. And we don't have the money, and it's not sustainable.
Okay, and on these in-school programs, do the schools provide anything in the way of funding or facilities, or they give you a classroom, I assume, or
You
whatever?
can use a classroom to do the therapy in,
Yeah.
but that's about it.
They don't.
The schools themselves do not
No.
pay.
Sure. Okay. How much time we got?
She's got
all night.
As much time as you need. Go ahead.
Well, I don't, there might be other, oh, okay.
They're trying to answer your question.
I'm sorry, I can't hear you.
I'm Carol Santos with Changes, and we treat mental health for teens and adolescent and children. A lot of the schools that I'm going into are using Lilly grant funding for the social emotional learning, but again, it's limited, so they're putting in reset stations and, rooms where the kids can go to calm down. All the schools, like one school has a dog. I mean, it's really interesting and wonderful to see the schools coming on board with what that is, but it's not ongoing. It's grant funded.
Okay. I got one question, maybe I'll do that if I could at the end after we've heard from everybody else. And that's it for now.
Okay.
Thank you for the presentations and the information. Medicaid is a priority in the state of Indiana. When you budget, you do by priorities. It is the largest expenditure of state and federal money at over $8 billion a year, more than K through 12. So we spend the most on this. So to see large changes in rates, I think is going to take a lot of effort of the Medicaid team. Dr. Sullivan, who's the director of Medicaid, has said that she wants to come up with a program to review rates periodically and look at all rates. But in reality, we pay better. We only pay about 20% of charges, if charges are actual cost, to most providers, except hospitals and nursing homes. So that's where Medicaid seems to pay the most because of what they've done and lobbied at the State House. But to see big changes coming in the future, I think, is going to be the need of the administration come forward and suggest it.
How often, when they're
hospitals, how often do they look and see, like, if it was a mental health issue that put them in the hospitals, and how that funding would be better used for, like, the preventative services or
They don't make a difference. It's on diagnosis code, and the reason they pay is because there's a tax on hospitals that goes back into reimbursement of the hospitals.
is that something that can be looked at, like, going forward?
Should we tax you to pay you more?
I'm sorry?
Should we tax you to pay you more? We have one yes.
Depends on the math.
I just have one question then for you. You said, you know, and I can understand it's a tall order to move Medicaid rates, reimbursement rates. But if there was one or two people you had to twist the arm of, who would that be?
You have to go to the director of FSSA, Dr. Sullivan and Allison Taylor, who are in charge of Medicaid at the State House.
Okay, thank you.
Well, I'm on the Medicaid Advisory Committee, and I actually work with Allison Taylor and these other people, so hopefully this is something I'm going to learn more about. I definitely see mental health as one of the biggest issues we're dealing with that has to be addressed at the preventive level, the in-crisis level, and the support to make sure that mental health services are occurring, because once we have this, once somebody has a mental health issue, it's not like it goes away. This is something that is long-term. I see it affecting so many things, from, you know, our schools and the costs that it costs our schools to the Department of Child Services, and that impact when we're dealing with the children of substance use parents or mental health issues has grown phenomenally over the years. Our jails are bursting at the seams. We need mental health services. I know that I just met with the opioid task force, and it sounds like they've made some progress. That sounds really encouraging. They're doing the pretrial interviews, and that sounded very promising. They're starting to identify those people that need mental health services to make sure that they get that service that they need. So I'm really hoping that we learn more about what we could do in our community. I think it's so important that we continue to communicate. I know that I have met with a lot of our mental health groups and providers. I'm dealing with mental health in my own family. So there's, you know, I get it. I know what the, you know, what's happening. I know what it's like to have really good insurance and have a real struggle to get mental health care for your child who's suffering. So this is something that, you know, it definitely has grown. I saw that our prisons did not get an increase in any funding. I went to visit our local jail and 3 prisons in our state to see what is happening at those levels. And 90% of the people in our jails have a mental health diagnosis. I know we closed down our institutions, but I'm from the Westville area, where it used to be a mental health hospital, and now it's our prison. And I have a feeling it still has the same people in it. So there's a lot to do, and I really hope that I can work to make some of these solutions happen. I know I've met with a lot of you. I've got a couple bills that we're working on. I know one of our biggest issues is transportation. So I do have a bill trying to address some of that presumptive eligibility transportation so that people can get transportation, because, you know, the limit to getting access is also being hindered, you know, so even if they can get into services, they're not getting there because of the transportation issue. So that is something that one of my bills is addressing. The lack of providers, I know there's so much that we need to do. We did talk about, one of the bills that I have is working on trying to get licensures sooner. One of the things that was addressed was that the board that was approving the licensure was only meeting every other month, which was causing a delay in getting people approved. I'm hoping with my licensure that we can get a permit in place so that they can start practicing while we're waiting for that final approval to go into effect. If they have a license from another state, it would have to be equal to the license that they're trying to get. I'm still working on that bill. I want to make sure that it's right before that, I will consider filing it. But, there's a lot of things that we need to do. So I'm going to continue to work in that area too. Thanks.
Well, in concluding this evening, thank you, each and every one of you, for great testimony, and thank you for what you do for our community. We really appreciate it. You've made a great difference, and I know many of you personally that work with both our children and our adults in this community, and it's not decreasing. It's increasing, and the need is increasing, and I see that every day. And as a former teacher, I saw children in the classroom that really needed services. Now, a huge issue I do want to tell you was not just reciprocity, and that's very important for our getting not only our folks into the state that perhaps are licensed, but also teachers moving from state to state. But the huge issue is having folks understand that Indiana is on the cutting edge in business, but with that comes a lot of different problems and different families coming into our district that perhaps have mental health problems and have not seen reimbursement. But a huge issue in our interim study committee in education this summer was parental consent and allowing parents to know that you're working with their children. There were feelings, and I think Senator Boots mentioned that, there were feelings on both sides. Do you let the parents know that you're treating the children? Or the parents say, no, there's nothing wrong with my child. I don't want you to treat them with that type of situation. So this is an issue, not just reimbursement, but parental consent, and knowing that you're admitting that your child has a problem, which may go back to something that's happening in your home at the time. So I think we have to deal and be very careful dealing with those issues, but I think they are right in front of us, particularly in education and budgeting and lots of other mental health questions that we have. So I hope that you will tell us as professionals, you being the professionals, some of us maybe having dealt with mental health issues, but certainly not the expertise that you folks have. You need to tell us what we need to do, and we will be working on Medicaid reimbursement. That is a huge issue in this state, and we want to make sure that our folks are able to stay in the state, work in this area. I've been dealing with DCS, as many of you know, for a week, trying to get reimbursement. It's going to happen next week, I'm promised, for those folks that haven't been paid for a couple of months. But we want to deal with these problems, and we want you to let us know, what do we need to do to simplify the system, which you mentioned, several of you, and tell us what avenues you think we should address in order to get there the easy way. Thank you very much, everybody, for what you've done today. Thank you, and tonight.
Okay. Am I on? There we go. Okay, I know I promised that, I made a statement about questions. We had time for that. Unfortunately, we're beyond our drop dead time, so apologize for that. But hey, I would like a hand for the folks who made the presentations for us tonight, if you could. Once again, I want to thank everybody for attending. We had a nice turnout by our legislators tonight, so that was great, and we appreciate you coming and listening to us. And so, again, I'll send you on your way tonight.
And thank you, Ken, for your work. Thank you.
There's one person that did promise a question to.
Okay.
Dustin, are you here? Okay. That he just wanted to share something. He wanted to be part of the platform. I did promise him that.
Oh, okay, that's right, I remember that.
Yeah.
I remember that, yeah. Sorry about
Share
that.
his concern. And then the other questions, we can funnel and get answers from the legislators, and I will personally, if we have your email address, we will get you a response. So we apologize for going over. We were really ambitious.
Yeah, I really, thank you all for being here. And I'm looking around the room and there are some heroes in the mental health field and addiction recovery services field in this room. And thank you guys for what you continue to do in our community. I get to work on a daily basis with some of you. I'm a person in long-term recovery myself. I got sober at the age of 23. Been sober for 18 years now in our community. I'm a purveyor of mental health services. I have over the years struggled with finding those services in our community. Recently, it's come to my attention that we have a legislative gap in the continuum of care in the state of Indiana. Ms. Klinker, I think I've talked to your office about this.
Yes,
I
you did.
want to continue this conversation. In the state of Indiana, if somebody in this room were to go into cardiac arrest right now, we would dial 911. The 911 operator would stay on the phone with us until services arrived. They would take that person to the hospital. A cardiac thoracic surgeon would take care of them. There would be an aftercare treatment program in place, including diet, aftercare, therapy, to help find the services that they need to prevent that from happening. Part of that's due, in fact, to insurance companies coming in and saying, we don't want a repeat of this cardiac arrest because it's expensive for us. In the state of Indiana, when a person like myself enters a mental health or a substance use crisis, there is no 911 for us to call. In fact, this afternoon, my phone rang with an individual who was suicidal, who had relapsed, and we couldn't find him. And a group of us gathered together to stand in his driveway, essentially, until he could be located and taken to an emergency room. There are these gaps that exist in the continuum of care for substance use in the state of Indiana, and one of those was introduced in 2017 in House Bill 1006, which specifically dealt with legislative oversight for recovery residences in the state of Indiana. They serve a vital role in our continuum of care. Oftentimes, they're either the entry point for folks seeking recovery, or they serve as a transitional phase for people leaving long-term residential treatment as they're transitioning into living on their own, sustainability in our community. And I can't thank the people in the room who do this daily enough for the job that they do. However, part of that bill says that there is no legislative oversight for those recovery residences that do not accept money at the state level, either from Recovery Works or some other grant program. And what that leaves is this subset of recovery residences that are free to do whatever they please.
What would you suggest that we do to take care of this problem immediately?
Read the email I sent your office a couple of weeks ago.
Tell me.
I would love for Peter to call me back. We should visit. But I detailed a multi-phase, multi-year approach. The first of which was that we identify all of those recovery residences in the state of Indiana. Year one is simply to identify. Where are you? Who are you? Who are you treating? How are you treating them? And year two would be that they would be asked to conform to the Indiana Affiliation of Recovery Residents minimum guidelines. I think the bare minimum we can do for the folks suffering is to offer them a minimum level of care. We do it in all other fields. There's like 200 hours of required education and then a state licensing board to be able to cut hair in the state of Indiana. But if you want to open a recovery residence in the state of Indiana, you need no certification unless you take money from the state.
Does that mean 911 for mental health?
I would love it.
Folks.
Is this the start of that?
I wish it were.
So I appreciate you guys
wish it
listening
were.
to that. I would love to further that conversation at some point, and I'm also willing to answer any questions. I know we're late, but I think it's important.
Let me just say that our current sheriff is working really hard in the mental health area, in the jails, because as you just heard, most of our folks have a mental health issue.
Sure.
Or they wouldn't be there. And so I do want to say a positive step has been taken by putting mental health folks into our prisons, but those that are in recovery that are out, you're right, do not have that access quickly. And probably we need some type of a 911 situation to help our mental health crisis patients. Thank you.
Thank you.
Okay.
Thank you,
I guess
Ken.
now I can say, that I appreciate everybody coming, and trust you have your winter coat. It's going to be cold tomorrow morning. So,
Thank you, folks.
see you on the way. Thank you.